everyone. I'm speaking to you from Sydney, Australia, where it's now 8 o'clock in the evening. We're coming to the end of our summer and it's pretty warm outside, so forgive me for just wearing my t-shirt. We've had a lovely sunny day today, and I've been out walking around the harbour, so it's nice now to be in at the evening and to be sharing some thoughts with you and having an hour for some Q&A. I'm an expert in infertility. I trained in the UK, in Edinburgh and in Oxford, and I ended up working in Sheffield for 12 years at the Royal Hallamshire Hospital. And then we emigrated to Sydney almost exactly 10 years ago now. I have a fairly big practice in IVF and fertility problems, also do quite a lot of gynecological surgery. But I think one reason I'm speaking to you this evening is that I've had an association with the Pituitary Foundation for over 15 years. And I've always worked with endocrinologists on some of the more challenging and interesting cases in the fertility practice. So have a fair knowledge as a non-specialist in pituitary endocrinology and pituitary dysfunction. Just as by way of a background, we see a good number of patients, men and women each year, who have problems of pituitary disorder. The pituitary makes the hormones FSH and LH, as you well know, and they're the hormones that regulate the function of the ovary or the testis. And so if there's a lack of these pituitary hormones, the reproductive system can shut down. It's usually not too difficult to wake it up again, because it's possible to purchase injectable FSH and or LH. And we use those hormone drugs every day in IVF practice, and also to induce ovulation and induce manufacture of sperm in the male. They are usually administered by injection. You can't have oral FSH and LH, unfortunately, but we have good injector pens. Many of you will be familiar with injector pens in other circumstances. They're not difficult, and generally it's a once-a-day injection. We also have long-acting FSH if we need it. One thing to be careful of, people associate fertility treatment with IVF, and in many cases of pituitary disease, IVF is not necessary. It's a hard thing to do. It can be expensive and difficult, but frequently if the problem is just lack of one of these hormones, the hormone replacement can fix the problem. So for example, if someone doesn't naturally have FSH in her body, we can inject FSH that can induce her to ovulate. And then if everything else is normal with the male partner and the anatomy of the pelvis, she can have a child without having to do IVF. So don't always associate fertility treatment with IVF. May be necessary, but not in every case. IVF has become big business around the world. In Australia, 1 in 23 babies is now an IVF kid. And in the UK, it's about 1 in 40, and that number increases every year. Availability is not a problem now, and having worked for many years in NHS, I know and you know that NHS is not particularly kind to people with infertility problems, so the majority of people doing IVF in Britain will have to pay some kind of money for it. Costs will vary. The unit I used to run at the Jessup in Sheffield was fairly low cost, but for other clinics it could be £5,000 or £6,000 per cycle. Do look around. Don't always go just to the nearest unit to you. There are many other units around most cities in Britain now, and it's possible sometimes to find one which is good quality and maybe not too expensive. And then maybe finally, just in this little preamble, the UK has a group called the Human Fertilisation Embryology Authority, the HFEA. They are government funded but arm's length, so they're not part of the government, they're independent. And I would recommend to you their website, just hfea.gov.uk, because they have lots of resources for patients and people with problems that are authoritative. Clinics generally boost their own figures as much as they can, and they may not always be objective, but HFEA is there to help you, to help people who need information. And I do recommend their website to a lot of people, even here in Australia. I ask them to go to that website because I think it has good quality information. So I'm here at your disposal. I'm happy to do my best to answer any questions. I would say that I can't replace your own doctor and your own clinical team. So please regard anything that I say to you as general advice and raise points with your doctors and your nurses as you wish. You're welcome to quote me if you want to, but I can't give specifics about every particular problem that we encounter this evening. So, Pat, I'll bounce this back to you now, and maybe we could start with the first question. And you're muted.
Typical Zoom. So Sean sent you ahead some questions, Bill. Can you start with those, and then we'll get them from the audience that are here today, or here's one.
Sure, okay. So the first question was, what fertility treatment options are available for women who do not ovulate due to issues with producing the estrogen hormone? I think I understand what this is about, because as I'm saying, if the pituitary does not make FSH and LH, the ovary goes quiet. The ovary is the structure in the body that makes estrogen. So naturally, as the woman makes her follicle with the egg that grows each month, she's going to ovulate 1 egg a month. As that egg follicle grows, the estrogen level in her body goes up. And then after ovulation, she also makes the hormone progesterone. That will be there for 2 weeks, and then the levels of these two hormones fall, and she gets her next period. And that process goes round and round in healthy people from when they have their puberty, maybe at 12 or 13, up until menopause at 50. So if the pituitary doesn't make FSH and LH, that whole process shuts down, very little estrogen. And so in a way, that person experiences the same physiological situation as someone who's in her menopause. So without estrogen, there'll be hot flushes, night sweats, mood swings, problems of vaginal dryness, loss of libido, sometimes concentration problems also. And that can be dealt with in 2 ways. If the woman doesn't want to be pregnant but just needs to be treated for these problems, then it's possible to take estrogen as a tablet or a patch or a gel. There are various ways. But if she wishes to be pregnant, as I said earlier, provided that the male partner is healthy and that she's had an ultrasound scan to say that the uterus and the ovaries are healthy but just quiet, injection of FSH with, in this case, LH will be necessary to induce ovulation. So once a day injection for about a fortnight. And if that's working, then ultrasound will show the growth of an egg follicle in the ovary, and blood tests will show the level of estrogen rising. That in its turn will make a lining grow in the uterus, so the lining is ready for implantation. And then it's possible to give a shot of LH to ovulate. We tell the couple when to go home and have intercourse to become pregnant. And the production of the pregnancy is fairly natural, doesn't need an IV for anything complicated. Because there's no FSH and LH, you would have to keep taking some hormone treatment into the pregnancy for a few weeks. But once the pregnancy gets to about 9 or 10 weeks, quite remarkably, the baby and the placenta start making enough of their own hormones. And so you can stop all hormone treatment, and the natural hormones from the pregnancy will take you all the way through to labor and childbirth. Pat, was that okay, or is there anything you want to bounce back on that?
That's fine. We've got some questions plopping in, so shall I read those out to you?
Just whichever you'd like to do, just one at a time.
Yeah. How long would you need to have injections for? Is it just for the duration of trying to conceive?
Usually, yes. So, as I say, estrogen lack is harmful. All of those symptoms are a real nuisance to people. They're unpleasant. And also, without estrogen, it's possible to develop osteoporosis of bone. So your doctors will want you to have estrogen replacement. But that nowadays we do usually with the estrogen gel or a patch or something like that. So that's much easier than injecting. However, that won't make a person ovulate, so it's not useful for fertility treatment. So when this woman would like to have a child, that's where the injections would be useful. The only reason I'm hesitant is I have a really lovely patient at the moment who's someone who never made LH and FSH from childhood. And so her uterus was very small. And she was told by doctors when she was a late teenager and investigated for lack of periods, she could never be a mom because the uterus was too small to carry a baby. And she lived with that for over 15 years and was devastated. You know, as many of us feel, being a parent is a really important thing, and she felt she was going to be denied that. But then went to a new endocrinologist who realized that the reason the uterus was small was not because it was unhealthy, it just had never seen the hormones that it needed to grow. And so what we did with her was to give her the injections to induce ovulation for 4 monthly cycles without trying for pregnancy, because the uterus had to grow before she could safely carry a child. And after those monthly cycles, with a period at the end of each month, you could see on ultrasound the uterus was growing. You can look at blood flow and see that improving. She was making a good lining. And we're now, right now, at the point where she can try to ovulate with these hormones and have intercourse to become pregnant. So occasionally you might need quite a few cycles, but that's unusual. Usually the uterus is growing fine, and so it just takes a few days of injections in order to produce the egg. Okay.
Thank you. For males, how long before trying to have children should you start with the injections?
The male is different. Often the testis will need to see LH and FSH for several months before sperm production begins. Again, I have a very nice patient. He's a vet, and vets understand all of this because they use these hormones often in the animal world. And so he came to see me and said, I've got this pituitary problem. I don't make FSH and LH. This is what I need. All I need you to do is write the prescription and away we'll go. And he was absolutely right. But it took about 4 months before any sperm appeared in his ejaculate. So you have to give it time. Often the man has been treated with testosterone replacement, which is important, similar to estrogen replacement in women. That in itself will suppress sperm production. So you'd have to come off your testosterone and let it wash out of the body, which takes a little while, and then begin the FSH and LH injections. You should begin to make your own testosterone. So you'll notice that you masculinize, you feel more masculine, hair growth, etc. happens. Sex drive will increase, but then later sperm production will happen, and it's easy enough to check maybe every 6 weeks to do a sperm test, and eventually sperm will be there. Sometimes the amount of sperm that are produced is not enough to get a natural pregnancy. It's really variable from one person to the next. And so it might be necessary to do an IVF, perhaps with ICSI, where you inject the sperm into the egg in order to have a pregnancy. But in many cases, again, make sure that the female partner is healthy and has an ultrasound and hormone checks to make sure she's ovulating and is fine. In many cases, a man who's having this treatment can get a natural pregnancy with his partner. And then again, once the pregnancy is established, you can stop the injections, go back onto long-acting testosterone, and establish a nice level of testosterone to stay healthy.
This person is asking, how can excess cortisol affect fertility and pregnancy?
Good question. I'm assuming we're talking about the female, so cortisol can suppress the function of the ovaries, so ovulation can switch off and periods can switch off if the level of cortisol is too high. Often with treatment, the cortisol can come down and the block is removed. I don't think it would be wise to go into a pregnancy with too much cortisol. It would be better with an endocrinologist to work to achieve some kind of suppression and have some treatment depending on the cause of the excess cortisol, whether it's a pituitary problem or an adrenal problem. That takes some specialist input, as I'm sure you're aware. But I think with a treatment to reduce cortisol levels, it's perfectly reasonable to expect to have a good pregnancy. In pregnancy, probably frequent blood monitoring to make sure the cortisol stays within the normal range. And again, close liaison between endocrinology, obstetrics, and perinatal medicine for the care of the baby.
If one has inflammatory disease of the pituitary, how safe is it to have a baby? Is it higher risk and even safe given that the pituitary grows with pregnancy? And what kind of monitoring is needed if so?
Sure. Again, good question. And it's a sad thing to have inflammatory disease of the pituitary. We all have sympathy for many of the people who are on the call today struggling with these problems. And I think the good news, though, is in pregnancy, the woman's body makes natural steroids. Estrogen and progesterone are there in large quantities, and most inflammatory diseases go quiet in pregnancy, and that would include inflammatory disease of the pituitary. Again, I wouldn't take a chance of conceiving without close liaison with your pituitary specialist, but in general, pregnancy is acceptable. in inflammatory pituitary disease and the likelihood of a problem is small, it's perfectly okay to have pituitary imaging in pregnancy if that's necessary, and also obviously hormone checks can be done. And generally the most important thing to watch out for is after the baby's born, the natural steroids disappear, so it's possible to have a flare-up postnatally after the baby's been born, and that's the time when you'd have to be monitored particularly carefully by your doctors to make sure that any sort of flare-up was managed properly.
This lady's had transvenoidal surgery for a Rathgay's cleft cyst in 2019. Prolactin levels are around 1200, but FSH and LSH levels normal. Regular menstrual cycle, but has permanent DI from surgery.
Yeah.
She's been forewarned that if she wants to have children, then she'll need to include her endo team. What support will be possible and what are the risks to this lady's health?
Sure, and that also comes back to a couple of the questions that were sent in beforehand. It's good news that the surgery has not destroyed the anterior pituitary and that she's still able to make FSH and LH. And I'm assuming also TSH, so thyroid function, is also normal. I'm sure that the doctors will have checked that many times. It's perfectly okay to take desmopressin in pregnancy. Back in the 80s, there were lots of theoretical anxieties about the possibility that desmopressin may cause contractions of the uterus or problems of blood flow to the placenta, so the baby may have been small. Also concerns that taking desmopressin in the early part of pregnancy may cause a teratogenic effect, so harm to the growth of the baby and development of the baby. But now in 2021, it's pretty easy to look in the literature and see many, many case reports and case series of women who've had diabetes insipidus who need desmopressin, who've had healthy babies. But the point that your caller makes is exactly right, that working closely with the endocrine team in a tertiary center with good obstetric liaison with the endocrinologist and then good liaison with the pediatricians when the baby's born is essential. But I don't think that use of desmopressin should stop someone thinking about having a child, and just organize close liaison with your doctors, and usually the outcomes that have been reported around the world have been good.
Another lady has come in with a very similar question, so I think that's addressed that. It was.
I'm sorry, there's one thing I also wanted to say, which is you can also breastfeed when you're taking desmopressin. The appearance of the drug in breast milk is in very small amounts, and there have been a good number of case reports of, healthy function, healthy production of breast milk, and babies growing healthily with breastfeeding. So again, we try and encourage all our moms to breastfeed if they can. And just because someone has diabetes insipidus, it doesn't mean that they shouldn't be advised to breastfeed. Okay.
Thank you. This is from a male. What would be the best approach if I suffer with unregulated acromegaly, taking pegvisomant and somatostatin, but we still wish for a pregnancy? Is it best to stop medication, or can a safe pregnancy still occur?
I would be very careful about stopping medication without, close liaison with your clinical team, because unregulated acromegaly can do permanent harm to your health, as I'm sure you know. So please be careful before making any decisions about this. The first thing to do really would be to have a referral to a fertility clinic and go and do a semen analysis and see if there are sperm present. If so, and the sperm quality is good, it's important also to work up your partner or your wife to make sure that her health is good and her fertility is good. But as I said earlier, quite often medication has an effect on the number of sperm and the motility of sperm that a man produces. And so if the sperm test shows that there are some sperm present, but maybe not enough for a natural pregnancy, then IVF would be the way forward. Maybe, as I said, with ICSI, so even with a very small number of sperm and very low sperm motility, men can now father children using these technologies. And so the need to resort to donor sperm these days is really quite rare for this group of patients. Donor sperm is available. It's possible to have a child with a sperm donor, but generally men with pituitary disease can produce enough sperm to be a genetic father to a child. The only other thing to say on this one is be careful about genetics, because sometimes pituitary disorders are part of a genetic problem. You can be a carrier of a genetic disorder and be affected by it. And so just be careful that you talk to your endocrine team and make sure that a baby would not be affected by the similar genetic disorder that has had an effect on your own life and the problems that you have.
So that question came from a female. I do apologise. So
Right.
acromegalic female.
So the female situation, again, but it was good to talk about the male. I mean, men can have acromegaly as well as women. It's not something that is gender specific. So I think my answer was maybe helpful to somebody. From the female perspective, again, please don't stop medication without advice and help from your clinical team. The answer is the same. See a fertility doctor. The availability in every city and most towns in Britain, it's not too difficult. COVID has put things on hold. Most of my consults these days are on Zoom, and I do many consults on Zoom. This would be a good one for Zoom because it's advice and taking a medical history and explaining what can be done. You'd need to know whether there were regular menstrual periods. It's easy enough to track ovulation if there is menstrual period. If there isn't menstrual period because of pituitary disease, the same advice, provided that there was an assessment of safety in pregnancy for the acromegalic person. And here in Sydney, we have some obstetric physicians that work with us, and they would meet you before pregnancy and make a plan of management. And I know from experience in the UK, certainly my work in London, work in Oxford, work in Edinburgh, work in Sheffield, all of those cities had obstetric physicians that would do that job, and I'm sure they are present in most of the other cities and big hospitals in the country.
I presume this is during pregnancy, but does steroid replacement for deficiency need to be increased or increase only in sick day? I'm wondering if that's within pregnancy. So if you've
it's
got
really interesting to see someone who has maybe had a very premature menopause because of some health problem they have. It's still, even after menopause, not too difficult with estrogen and progesterone to make a lining grow in the uterus and to make it receptive for pregnancy. And then those hormones, the estrogen and the progesterone, have to be continued for 10 or 11 weeks of pregnancy. But then we do a blood test, and it is quite remarkable. You look at the level of progesterone from the medication, and it will be going along maybe at about 30 or 40, and then suddenly it zooms up above 100 in the course of a week. And that's because the placenta is making the person's own progesterone. And once you see that incredible increase, is very rapid and very dramatic, you see that increase, it's called the luteal-placental shift. And when the placenta has started to do its job, you can wean off all of those steroids, not necessary for the rest of pregnancy. But as I said before, be careful, because when the baby's born and the placenta's delivered, those natural steroids will disappear quite quickly. And often people with all kinds of steroid deficiency problems will have a flare up. And so your doctors have to be ready to treat you. And sometimes you need bigger doses for 3 or 4 weeks or even longer as you go into the first part of living with your new baby and need to be managed and get back into a stable condition after the baby's born.
This is from a mum. Her daughter is 13 and has hypopit. She is already on HRT for the menopause. She's asking, are you saying there is a chance she could still carry a child even if it is in 20 years' time?
Yes, the answer is there is a chance. Very, very sad story. And I feel, a lot of sympathy for anyone who has a young child who has hypopit, and there is going to be many years of having to take replacements to stay healthy. But our knowledge of the hypopit conditions is good these days, and your doctors will know what she needs in order to have healthy growth and development and bone health and all those things. But remember, hypopit is the pituitary disorder. There's nothing wrong in the pelvis. So the uterus and the ovaries will be there, and rather like the case I was describing, they won't grow and develop normally without seeing FSH and LH and estrogen. And so when she's on estrogen replacement, the levels are often not as high as they would be naturally. So she might be similar to the case I was talking about, We can induce ovulation. We can induce a menstrual cycle with these injections, not when she's 13, but when she's ready to have a child, when she's in her 20s or 30s. You might need to do that for a few cycles in order to allow the uterus to grow, allow its blood flow to develop. But there's nothing wrong with her ovaries and her egg store. That will just remain the same as it would be in any other woman. Even though she doesn't have menstrual periods naturally, the egg reserve will slowly deplete. So it runs out in her late 40s or 50s as natural menopause. And because it's going to be a little tricky to get a pregnancy going for her, if she can, by the time she's maybe 30, be in a position to start trying for a family, because it may take a fair amount of work with a fertility doctor and an endocrinologist working together before you can have a healthy uterus and have her ready for pregnancy. But I wouldn't by any means at age 13 write off the chances of her being a mom later on.
Next question. Males with a congenital hypopituitarism, is this likely to be something that can be passed to children?
No, not usually. It's what I would do if a person with this problem showed up in my clinic. We have access to a clinical geneticist, and she would undertake genetic counseling, would look at the cause for the hypopit in this patient, because often, as you know, these are developmental problems. We heard earlier from someone with the Rathke's pouch problem who had had surgery. That's unique to that person, would not transmit to offspring. So, and again, these are lovely Zoom consults. We don't need to have you personally in the consulting room anymore. It's easy enough to set up a Zoom. A GP could organize it to have a talk with a clinical geneticist if need be, and they could explore whether there was any possibility of transmission to the child. It doesn't mean you can't have kids if that's the problem, because these days with IVF, we can make embryos and we can test each embryo to see if the genetic condition is there in that embryo or not. And obviously you'd only transfer back to the uterus an embryo which doesn't have the condition. And so quite frequently people who are themselves affected by a genetic condition don't pass it on to the offspring. Just a couple of cases for examples. I have a lady who has the BRCA gene, the gene for breast cancer, ovarian cancer, that Angelina Jolie has, that many people know about. And she's gone through this process and she's pregnant with a little girl at the moment, and that little girl does not have the BRCA gene because we checked her embryo and it was okay. And there's another case at the moment with neurofibromatosis, which can affect the pituitary, certainly can affect the acoustic nerve and other parts of the brain. And then she had an IVF with this testing of embryos, and she's pregnant with a baby that doesn't have the neurofibromatosis gene. So if your problem is caused by a specific gene that we know about, and we do need to know which one it is, people keep asking me, for example, about genes for autism, and we don't understand why autism happens. So we can't do genetic testing for every condition. But if it is a single gene disorder that we understand, you can screen embryos and make sure that the baby is not affected, which personally I think is one of the nicest ways in which really clever science can impact on the health of people in such a direct way. Those are really nice cases to work with. So if you believe your condition might have a genetic basis, talk to your doctor and talk to a genetic counselor and make sure that you explore it before you have a pregnancy.
Thank you. Lady with inflammatory disease, she has no gonadotrophins and she has diabetes insipidus, borderline low thyroid. So she's asking if the risk is great with inflammatory pituitary during pregnancy, should they consider surrogacy instead, perhaps using own eggs but not carrying the baby. She has normal growth hormone and cortisol, but front and back pituitary is affected in terms of the sex hormones and DI.
So again, I can't give advice on specifics, and it is a question to raise with your endocrine team, looking at your own level of control and whether with replacement you're stable and your health is generally good, or whether there are problems that your doctors can't keep under tight control. But as I said earlier, it's possible to have your own pregnancy while taking desmopressin. That's been well explored. And it's certainly possible with gonadotrophin injections. The gonadotrophins are FSH and LH, we were talking earlier. With gonadotrophin treatment, you can induce the ovaries to make eggs. The eggs can be collected, fertilized in the lab using your partner's sperm, and then the embryos can be frozen. And then there's a choice to make, because if your health is good and if your doctors say that it's okay to be pregnant, you can have an embryo transferred to your own body and carry the pregnancy. But if there is anxiety about the possibility of there being a disaster in pregnancy because your condition is too brittle to be safe through pregnancy, you're absolutely right. The other option is to find someone who can be your surrogate. And that embryo, which is your DNA and your partner's DNA, is then replaced into the surrogate's uterus, and she would be pregnant, carry the baby, and give birth. The law says that the woman who gives birth is the legal mom of the child. So after the surrogate delivers the baby, there's some paperwork and a fast track kind of adoption process that you go through with a bit of help from a lawyer. And it's not difficult. And everyone signs the documents, and then you become the legal parents of your child, knowing that child has your DNA, and so therefore is connected genetically to the two parents. Surrogacy is a tough thing. Asking someone to spend 9 months carrying a baby that she'll not then have as her own child in her family is a hard ask. And it can work in one of two ways. Often the better way is if you know someone who loves you. It could be a younger sister, it could be a close friend. I'm doing a surrogacy here at the moment with someone's mom, who is reasonably young and healthy, and she's going to carry the baby for her daughter. And it's a beautiful thing when it works well, and everyone feels a reward at the end, and the family has a daughter, or this lady will bring her own granddaughter into the world. But not everyone is in a situation to have a surrogate who's known to them, and it is possible to recruit surrogates. In the UK, it's not legal to pay a woman to carry a baby. So the situation used to exist that people would fly to India or Thailand or some part of the world that was less regulated, and a woman would be paid to be the surrogate, and then the baby would be brought back to the UK. Personally, I think there are obvious ethical problems with that, and it's not something I'd recommend. And most of the countries that used to do surrogacy in that way have now prevented it by law. So I know that India doesn't allow it now, Thailand does not allow it. People, I think, are still going to Mexico and some parts of Eastern Europe. But can I advise you to be very, very careful before you go into a paid surrogacy arrangement? There's an element of lawlessness out there, because these are not in well-regulated countries, and highly preferable if you can find a surrogate who'll help you in the UK. There are women who volunteer. I have an ex-medical student of mine who I think came to one of my lectures and got interested, and she's been a surrogate twice because she loves helping other women. She finds it very rewarding to be pregnant. She's not had any kids of her own yet, and she does this from love and altruism and doesn't require payment. So it's difficult to find a surrogate outside of your own family and friends, but not impossible. And really be very, very careful if you embark on a overseas surrogacy arrangement. Be very cautious with that.
Thank you. Do you have any advice for macroprolactinoma patients? There is another query just below. Can cabergoline for prolactinoma be taken in pregnancy? They're two separate questions, but probably the same outcome.
Well, again, firstly, macroprolactinoma, you have to be very careful before you embark on a pregnancy and make sure that your doctors are happy for you to become pregnant and that the right treatment has been given. Sadly, often surgery for macroprolactinoma ends up with a pituitary depletion, and so you might need FSH and LH, as we've been talking about, in order to ovulate and conceive. But obviously after surgery, if it's been successful, the macroprolactinoma has been removed. However, in this case, there's still secretion of prolactin, so it must still be there. And yes, you can conceive using cabergoline. We don't believe that it's a teratogenic drug that would affect the health and development of the baby. What we generally advise is, as soon as you get a positive pregnancy test, you can stop your cabergoline, provided that your doctors allow that. But if it's there to suppress the macroprolactinoma, they might say to you that the benefit is greater than the risk, because the risk these days is small. We know a lot about cabergoline and development of the child. And so your individual circumstance, the answer might be in liaison with your pituitary specialist and your obstetrician to carry on taking the cabergoline into pregnancy. Pituitary imaging, usually MRI, is safe in pregnancy. You can carry on doing that. The blood levels can be monitored, and it's not impossible to have a successful pregnancy with your clinical team in sort of close liaison.
So the lady before that asked about her daughter, she's just saying thank you for your reply.
Thank you.
Quite life-changing, I would, yeah.
Well, the other thing to say there, Sean, is please go with your daughter, maybe when she's a little bit older, you know, age 15, 16, 17, when, you know, the young women begin to wake up to thinking about long-term planning and being a mom and family, and those things are important in theory for later. So it might be wise when she's growing up as a teenager to go and meet with a fertility specialist in a center, in liaison with the endocrinology team that are looking after your daughter's menopausal problem. And I do this quite a lot. It's about the theory. It's about what you might think to do later on if you want to be a mom. Obviously, there's many years before she's with the right partner and, you know, wants to be a parent. But it's a shame if young people go through their teenage years, their early 20s and so on, believing something which is not itself true, and can be heartbreakingly sad for someone who, you know, would like to bring a child into the world and believes that she can't. So even if there's not a plan to do anything to have her pregnant at this age, it's often nice to explore possibilities later on.
So that's it. Any more questions, anybody? I think you've covered so much, Bill.
Let's maybe just bounce back to a couple that were sent in before. One of them was asking about increased risks of miscarriage when going through fertility treatment, and the general answer is no, but fertility treatment doesn't reduce risks of miscarriage either. It's the same. A lot of miscarriage is about the quality of eggs, and so maybe as a general point to people on the call this evening or your morning, if you are planning to try for pregnancy, often there is complexity, there's a need for workup and planning and time taking. Try and do it in your late 20s, early 30s if you can. The biggest problem I have in my own practice is women who are coming to see me in their 40s, deeply driven to have a child, but left it too late. And then in your 40s, often we can collect eggs, but the quality is not good and it's very difficult to get a pregnancy going. And then the risk of miscarriage is higher just because of age. And also the chance of a chromosome problem like Down syndrome is higher. So general point at the end of our session is, if it's important to you to be a mom or a dad, do this either when you or your partner is not too old. That would be my sort of general advice to everybody this evening.
Okay, we've had some questions in now. How long after surgery would it be safe to consider getting pregnant, especially if you are adrenal insufficient?
I'm assuming we mean pituitary surgery.
Yeah.
I mean, you know, there's all kinds of surgery.
Yeah.
Well, again, I would have to bounce that back to you, because it really is a liaison with your pituitary management team, the surgeon and the endocrinologist involved. As I'm sure you know well through the foundation, people's recovery varies a lot. Sometimes surgery is more successful than others. Sometimes there is residual disease or everything seems to be cleared away. So I can't really give you a clear answer to that. Really, you have to go back and talk to your surgical and your medical team.
Thank you. How does age factor, this kind of is a bit the same as what you just answered, but it's particular for this lady. Yeah. How does age factor in along the path to plan for a child? So 34 years old, female, and know of my pituitary issues. What do I need to do now to plan for the future?
Fertility doctors, when they meet and talk about patients, only really ask 3 questions of each other. So suppose my registrar, my trainee goes and sees a patient and they come back to talk to me. The first question is, how old is she? The second question is, does she have a partner? And the third question is, does she have a sister? So age 34 is good. You should have good egg quality. And if you're in the right relationship and ready to be a parent, then, talk to your clinical team and try to become pregnant. If you're not ready to be pregnant at the moment at age 34, if you're single and don't have a partner, it's worthwhile considering freezing eggs. Now, there's masses on the internet about egg freezing, and it's a controversial topic, but the problem of waiting much longer, if you get up to 39 or 40, is this question of egg quality declining, which impacts on a lot of people's ability to be a parent. And so here in Australia, we do a lot of egg freezing for women that kind of age who are either professionally not ready to be pregnant, or frequently the story is they've ended a long-term relationship and they don't have a partner and they're worried about the impact of aging. So single woman age 34, think about talking to a fertility clinic about egg freezing, perhaps for later, rather than trying for a baby with your own eggs over 40 when things may not work so well. And equally well, if you do have a partner, embryo freezing works much better than egg freezing. Embryos are tough little things. They survive freeze thaw very well. An egg is a brittle cell, and so preferably we'd freeze embryos rather than eggs. But obviously the social question is the more important. You've got to be deeply in love with the right man before you can do embryo freezing. And so maybe egg freezing is an option for some people.
Is there anything as a male with congenital hypopit I should ask, and I should be mindful of and raise with my endo?
Well, firstly, testosterone replacement is a great thing for men with your condition, and it's life-changing in a very good way. And don't hold back. Work with your endocrinologist to get your testosterone level right and have good quality of life, and feel healthy and good bone development and good sex drive and so forth. But as I said earlier, when you're ready to be a dad, or equally, if you'd like to freeze sperm for later, that's something else that we can do. You would have to come off your testosterone and use FSH and LH to stimulate the testicles to start making sperm. And in a way, what I just said about women applies equally to men, that men remain fertile for longer, but men who have children in their late 40s and 50s, more frequently the child has problems with autism problems. Some thankfully rare cancers occur more often, and miscarriage rates are higher if dad is older, even if mom is quite young. So you might think about, depending on your own circumstances, doing the FSH-LH stimulation, and if you're not in a good relationship now, but getting a bit older, you could even talk to a fertility clinic and freeze some sperm and then go back on your testosterone again.
Thank you. What options are there for someone whose prolactin is very high, resulting in few periods, who wants to have a baby, but is unable to take bromocriptine due to other health conditions?
Sad story. Sorry to hear that one. Obviously, cabergoline is an alternative to bromocriptine, and I'm old enough to remember people taking bromocriptine. Many people had side effects with bromocriptine that were very unpleasant, and it was difficult really to continue sometimes with treatment. Many people do find cabergoline a good alternative, but obviously I'm sure this person's spoken to her pituitary doctors about this, and it's still possible with a high prolactin to induce ovulation with FSH-LH. It's not so easy, but it's not impossible. So it would be possible maybe to think about an IVF process, for example. But the fact that there are other health conditions, again, and I'm sorry I keep saying this, but do make sure there's good liaison between the endocrine team and specialist obstetric people who know about risk in pregnancy. So not impossible, but it would require a lot of thought and careful management and planning, and discussion before attempting a pregnancy is the most valuable thing. So go and talk to a fertility specialist in your own local city, in your own local clinic.
Thank you. Are there any other questions we sent over to you there, Bill? Have you any?
No, I think we've talked about desmopressin, we've talked about pituitary hormones, and we've talked about miscarriage. So those were the ones that we had to cover off, and I think we've mentioned all of those now, Pat.
Yeah, thank you. So there seems to be no more chats coming in, no more questions. Everyone's extremely thankful. And you can go and have your dinner and your glass of wine now, a bit earlier. I think you've answered them.